So in summary, this cesarean scar, pouch, or niche can be filled with fluid during regular scanning or fill with sonohysterography. It can be visualized on hysteroscopy and can fill during hysterosalpingography. It can serve as a reservoir for blood and be a cause of abnormal bleeding. What percentage of women who have had a prior cesarean section will actually demonstrate such a niche is really unknown. Here's another issue that can happen related to the cesarean section. This patient came with a request to check for the location of her IUD. On the transvaginal image, most of the IUD is actually in the endocervical canal, and a portion of it is right here. Further transabdominal scanning again shows a portion of the IUD right here, and there was no IUD further along in the endometrial cavity. This was the most distal aspect of it right here, and you can actually see that that's where the cesarean section scar was. We went back and looked through this patient's records and found that she had actually, interestingly enough, had a CT scan right after her cesarean section related to bleeding or a fever, and it allows you to see where the scar was in the myometrium right here. A year later, she had a CT scan for other reasons, and she had the IUD, and what wasn't noted was that the IUD was actually malpositioned. Here you can see one of the arms of the IUD exactly at the location of the cesarean section scar, and a reconstruction shows that the IUD was not really sitting well seated in the endometrial cavity, but had gotten stuck, we believe, in the scar and had to be removed. Next, we'll move on to the issue of tubular structures in the pelvis, or as I call it, beyond the uterus and ovaries. So the first pitfall here is that some people are somewhat short-sighted and figure that if they see the uterus and they see the ovaries, they're done. Unfortunately, or fortunately, it's not so simple as that. And so we'll turn our attention to the fallopian tubes. The most common teaching is that unless the fallopian tubes are abnormal, we do not see them. But I would argue that actually you can see portions of the fallopian tubes not infrequently. To review the anatomy of the fallopian tube, the fimbriated end and the ampulla are the thickest portions of the normal tube, and that's the part that you may be able to see. It's often more easily seen when the patients have some free fluid in the pelvis for whatever reason. This patient has a fair amount of fluid. It's a little bit complex, but you can see it outlines nicely the fallopian tube, and you can just match it up on the diagram. This is the thicker fimbriated end, and this is the normal fallopian tube. Notice the approximate thickness and appearance of it, and then I direct your attention to this patient who has no fluid in the pelvis, but you can still find the fallopian tube. This is more easily done when you're scanning transvaginally to stop pushing too much on the ovary and just lighten up the touch a little bit and go right near it, and you should find it. This is the uterus in transverse, this is the left ovary, and between the two is this little echogenic structure, which I would argue is a portion of the fallopian tube, probably the ampullary portion, and this is what a normal tube, if you see any of it, would look like. The problem with seeing it, as you can tell, is that it's fairly isoechoic with myometrium and often with the adjacent fat. These are two patients with the same diagnosis, and it's related to the fallopian tube. Both of them happen to have some free fluid, and that is allowing us to see this diagnosis. Here's the fallopian tube in this patient. This is it in transverse, and there's a little cyst right at the end of the fallopian tube. This is the fimbriated end, and it's sitting in there hugged by the fimbria. Here's another patient, a similar situation. Here is the tube with a tiny little cyst at the end of it. These are paratubal cysts, also known by their fancier name, hydatids of Morgagni, and these are normal fallopian tubes. Not infrequently, we only see the cyst and we don't really appreciate the fallopian tube, but I would argue that if you find one of these, you should look, and you might actually be able to appreciate that it's coming out of and related to the fallopian tube. These are innocuous findings. On the other hand, the fallopian tubes clearly can become abnormal and should be appreciated as such when that happens. These are two patients with pelvic inflammatory disease, and in these situations, the tubes are very thick-walled, there are fluid debris levels. These little things, in a transverse view of the tube, you see these characteristic little echogenic prongs or little projections into the tube. You can see them here as well. And these are the thick endosalpingeal folds. These are fallopian tubes in acute pelvic inflammatory disease. This patient also has an abnormal tube. She has a history of endometriosis, and here's the tube filled with some low-level echoes, which were blood. And notice, if you will, the sort of indentations on either side diametrically opposed. This is the so-called incomplete waist sign, which has been described as a quite specific finding for a dilated fallopian tube. You can see the tube sitting on top of the ovary. This patient was sent to us for evaluation of a cystic tumor discovered on an outside ultrasound study. And this is one of the images that she brought with her. It looks like a cystic lesion, presumably in the ovary, they thought, with some septations. Further imaging, however, shows that this actually is a structure that's curled back on itself. It has an incomplete septum, and we actually were able to find the ovary next to it. This represents a chronic hydrosalpinx and shows the incomplete septum sign. This is not a cystic tumor. It doesn't need follow-up. It can be left alone, and the patient can be reassured. So, as far as dilated fallopian tubes go, the best markers for dilatation is the waist sign, or the small round projections into the tube. The incomplete septum sign can be useful, but is felt to be less discriminating. If the tube is thick-walled and shows a cogwheel sign, that is typically acute disease, whereas a thin wall and tiny little beads on a string are from chronic disease. And these are some diagrams from an article by Timur Trish illustrating the cogwheel sign, the thick wall with the projections. Here's a thinner wall with tiny little projections. And this is the dilated tube curled back on itself with the waist sign or incomplete septum. Now, there are foolers of fallopian tubes, and these are some of the pitfalls that you need to be careful about. This patient came to us with a history of pelvic pain, and the diagnosis was made on this study of PID with a dilated infected fallopian tube. This is the measurement of the structure they were calling the fallopian tube. You can see low-level echoes. They turned on the color and saw some flow in the wall, which is not uncommon in an acute pelvic inflammatory disease. However, the clinical findings did not seem to coincide with this diagnosis, but nonetheless, she was treated with a course of antibiotics and returned for further imaging. Here's further imaging of what the tubular structure looked like at this point. Again, it looked lobulated and tubular. It had a fluid, low-level echoes, but this time we looked with color Doppler and made the imaging more sensitive. You can see from the numbers here. And lo and behold, we could see flow coming in and out of plane through this entire structure. And what this actually represents are dilated veins or varices in the pelvis, and they have often very slow flow, and as a result can have internal echoes. Demonstrating flow in color Doppler will require very sensitive settings, and occasionally the flow is so slow it won't show up in color Doppler, but you'll actually see the little low-level echoes floating by. Now, distinguishing these from fallopian tubes is clearly important, but also they can have significance in and of themselves. This patient came to us with a history of chronic pelvic pain. She actually, when we reviewed her folder, had multiple sonographic exams and multiple CT exams, all of which had been read as negative. When you look, however, this is not so negative. In her left adnexal region, she had numerous dilated veins. These are all varices. And if you look carefully in the grayscale of these images, these veins in the adnexa connect into the veins in the uterus. You can see she has fairly dilated veins all in the periphery of the uterus connecting out. This is one of the many CT scans that she had. You can see that at the level of the aorta and inferior vena cava at the renal level, she had a dilated right ovarian vein, and you can track it down to the pelvis. These are all the dilated varices on this side, predominantly on the left side, some on the right side. And this patient went on, because of her symptoms, to have an IR study. This is an image of the veins in the pelvis with the catheter in place. And this patient, we confirmed the diagnosis of something called pelvic congestion syndrome, which we treated by embolization of the varices.